Hi, thank you for having me here. I'm Jeff Siracuse. I'm the Chief of Vascular Surgery and Professor at BU. And I work on this project with Tommaso Ranzani, a great example of cross-campus collaboration at the College of Engineering. So we looked at the resuscitative endovascular balloon occlusion of the aorta. This is used minimally invasive intervention that's used for temporary control for major torso hemorrhage below the diaphragm. This was initially started in the military and gained popularity in the last 10, 15 years at trauma centers throughout the world, but its popularity has gone down. What's important is it temporizes things. It maintains coronary cerebral perfusion by putting a balloon up in the aorta during massive trauma, especially in the abdomen. However, the downside of that is that it can cause distal ischemia further down. Local access complications, kidney failure, leg ischemia complications, people requiring amputations in the future, going on dialysis, having paralysis from this, severe global physiological derangements from long-term inflation of the balloon till definitive hemorrhage control in the operating room. Multiple publications have come out with this causing downside, and someone has fallen out of favor in a lot of trauma centers. The innovation here is there a way to maintain some perfusion, some flow to the head and the coronary as well, still maintaining flow distally? There's been other models of intermittently going up and down it, but this has been uncontrolled and not done well. So we wanted to know a control way for the mean arterial pressure to maintain it during a traumatic event. And so you can see here an example where you expand it up and you have a pressure sensor pre and post of the occlusion, so you can tell your flow above the occlusion, your mean arterial pressure, and your flow below. And is there a way to control this and titrate this for each patient to have enough protection to maintain coronary cerebral perfusion but not be having distal ischemia? So our approach was, and for this we got a Boston University Clinical Translational Science Institute Integrated Pilot Award for this, both Dr. Ranzani and myself. Is there a way to develop a device that would do this? So 3 components of it: a stabilizing mechanism, metal component to expand up to 30 millimeters and support the structure to avoid shrinking, collapsing, soft actuators made of PTFE and a thermoplastic elastomer that can go up and down and be titrated, and also sensors as well that can be accurate within 5 millimeters of mercury between a map of 0 to 130 of pressure for control, just to show that we have stable repeat measurements. The goal is to have in vivo and ex vivo pig models with this and take this and apply for a larger federal grant. Specifically, look at pig models, so look at post-mortem after we do the occlusions based on different pressures, looking at the ischemia in the brain, the heart, and also the kidneys and the distal muscle. So we look forward to hopefully having some more data to show at some point, but I think this is a good, promising technology example of cross-campus collaboration.